And in the morning, I'm making waffles. Name that movie. Welcome, dear friends. Part 3 to Snowboarder Knee Series. Today we are talking about some interventions for ACL tear rehab or strain rehab, and then meniscus tear or strain rehab as well. If you haven't seen Part 1 and Part 2, please check that out. Part 1 we talk about the basic anatomy of the knee. Part 2 we talk about the most common injuries. And today is the most exciting part, are some things that you can do in your recovery. Before we get started, my name is Mark. I'm a doctor of physical therapy, one half of Mobility Duo, with my wife, Sarah, who is a certified yoga instructor, massage therapist, high school teacher, all of the best stuff you can be. We are rehab professionals and athletes that love working with primarily snowboard athletes. Check us out. Subscribe. We put a lot of effort in these. We appreciate you. So how today will go is we'll go over some of the basics in regards to the healing timeline for meniscus tear, ACL tear, the healing timeline that if you choose to get surgery or if it's required, timeline for that. I'll provide some simple initial exercises that you want, but truthfully, if you're consulting with ourselves or if you're consulting with your local healthcare professional, there are thousands of protocols for these injuries. And I'm sure the thing about research is, you can usually find what you're looking for. So there are many different approaches. There is no one way, one size fits all to these. This is just my philosophy from the research that I've read and the way I was taught. The biggest factor in the healing timeline, as you may already know, is age, diet, fitness previously, stress, things like that. So all of those factors are major players in your recovery timeline. The other one is consistency of, how often are you performing these exercises? How aggressive are you being with your recovery? Because those who sit around and do nothing, are going to take longer to recover versus those who are proactive with their exercises, who are progressing, who are working with a healthcare professional. So keep that in mind. So like we said or talked about in part 2 of this series, probably the most common is your ACL tear. Super common, non-contact very often, so essentially you really don't even have to be in a sport and this occurs, or if you are, it's usually that planting, twisting motion. Many people can have an ACL strain, ACL tear, and not have any symptoms, maybe just have a little instability and have to work on those surrounding muscles above and below the knee to strengthen those. If you do have an ACL tear and you choose to get surgery, again, there are thousands of protocols. So general timeline for return to sport for an ACL surgery is 9 to 12 months. So keep that in mind when you hear someone who is, in a college or professional athlete who's getting an ACL tear. It's going to be probably a little bit less because they are under, the best doctors. They're getting the best treatments, stem cells, blood, plasma, all that stuff. But for the general public, 9 to 12 months. The other thing to consider with ACL tears, if you do have surgery, weight-bearing precautions that, you're going to have directly after the surgery. It's also going to depend on if you're getting a graft. So you can get a graft commonly from the patellar tendon, hamstring tendon, and even the cadaver. Cadaver is usually for an older patient who is not as active anymore, but I've seen quite a variety of between the hamstring tendon and the patellar. If you get one of those, you're also going to have that as a factor in your recovery. So those tendons are going to have to recuperate in just the same manner as the ACL surgery itself. There's a lot of research right now. It's a hot topic on people or clinicians who are against open chain kinetic exercises for the first 8 weeks. So what does that mean? That means essentially, let's say your leg is hanging off of a chair and you're doing just kicks, like a long arc quad or something. It places a lot of stress on the ACL, and a lot of people are against this there is another body of research that says we can be a bit more aggressive, within sometimes up to 2 or 3 weeks after the surgery. So that's really going to come down to what your surgeon thinks and what your physical therapist thinks. So for initially, the first few exercises that you'll start off with, I'm big on neuromuscular re-ed. What that means is kind of retraining your brain to, let's say if I squeeze my booty, it's activating when I tell it to, for a strong contraction when I tell it to. So sometimes, for example, you'll see someone who has a delay, especially in their quad muscle in the front, that big muscle in the front of your thigh. There might be a delay there, so I might start a patient off with, let's do 20, 30, 40, 50 of just like squeezing that muscle. I want you to make sure that you have a solid contraction every time. So once you get that down, I would probably assign you like a simple isometric, so like a quad isometric, a glute isometric, and we can hold that for 3 to 5 seconds, just working on that as tolerated. Remember, all this time you can exercise the unaffected leg. So if I have surgery on my left leg, I can work out my right as much as I want. I can work out my upper body, so keep that in mind. I can work on my core, shoulders, anything, all that stuff. So keep that in mind. Once you have those isometrics down and you're kind of going along the timeline, you can do things like a 4-way hip. So if you're standing, you can move your leg out, forward, back, in. You can do it on your side, things like that really you're not bending the knee at that point, but you're still working on your hip. As time progresses, you can work on other things such as a straight leg raise. So I might have an isometric in that quad on the muscle in the front, and then I will see what that contraction looks like. What I'm looking for is that bend in the leg. That bend is important because if I don't have that solid contraction, that can create some inefficiencies, especially when you walk, run, cut, push off, things like that. I won't dive in too much into more detail for that because I could talk for ages about it. But your physical therapist will use testing such as single leg hopping, triple hopping, cutting. They'll use kind of force production on how many pounds can you produce consistently between both legs, trying to get a percentage like a 90+% equally on both sides, just to prevent re-injury. So that's the last thing that anyone wants, especially the surgeon, is re-injury. So you want to make sure that, especially if you're going back into a cutting sport that requires a lot of force to push off that leg, that you want kind of even, consistent strength on both legs. Okay, moving on. We have meniscus tear, meniscus strain, you name it. Super common. So another hot topic, the meniscus tear. A lot of people, I've noticed, a lot of patients are very eager to get surgery, which I understand. I actually think I have one myself. I've had for a while. There is a lot of research out here that has compared kind of consistent physical therapy over a period of a few months or of a year compared to surgery right away. And over that year, a lot of patients have similar results. So keep that in mind. Again, research is variable. You can find what you're looking for generally. If you choose to not have surgery, which is what I recommend every single time for far majority of cases, many of these meniscus tears will get better or more tolerable with consistent strengthening over that 6 to 8 week period. If you are still having issues over that 6 to 8 week period, I might consider reaching out to your doctor, getting the ball rolling on potential surgery. Of course, talk to your local healthcare professional first, but you just want to get that ball rolling just in case you do need it. You have it ready to go. So return to activity after a meniscal surgery, usually 4 to 6 months. Return to sport ranges, but it's usually at 6+ months. Again, it's going to come back down to age, fitness, diet, stress, etc., etc. So someone who comes in with a acute meniscal tear or injury, it's really going to come down to tolerance. So most likely you're not going to injure it more than it already is, but there's going to be a lot of inflammation. Bending it's going to be uncomfortable. So it's going to be your standard RICE, compression, ice, elevation, protection, things like that. Once you are able to tolerate exercises, I'm a huge fan of isometrics here. So I really enjoy kind of your quad leg extension machine. So if I'm going up, I'll go up 3 seconds up, and then 3 seconds on the eccentric down. So a lot of these, the eccentric movement's going to be really, really hard, especially for a meniscus tear injury. So what that means is if you're going up, or let's say I'm on a squat, I'm going down. That slow movement down is kind of that eccentric movement. It's working backwards, and then you're pushing back up, driving back up for the concentric movement. So the eccentric movements are going to be extra painful. I'll start off with the isometrics and work up from there. I then might do, again, like that 4-way hip, again, standing, forward kick, side kick, back kick, inward kick. Initially, we want to be careful with your leg extension past 60 degrees, especially if you have surgery, just because it places more emphasis on that meniscus. And then again, you can work on other things aside from that. So you can work on hamstrings, really honing down on maybe like a Nordic hamstring. You can work on glute strengthening. You can work on hip strengthening, calves, core, upper body. So there are many other things we can work on. The biggest thing with meniscus injuries is we're not trying to over irritate the tissues, but we're trying to strengthen those tissues around it to support that knee. Again, these usually get better within that 6 to 8 week period. There you have it. A very brief overview, superficial overview of kind of the rehab process with your ACL tear, strain, or meniscus tear, strain injuries. Again, a lot of trains of thoughts on how to approach these injuries. It really comes down to listening to your patient, treating them like a person and working with them at their level. So, you don't want to undertreat them, you don't want to overtreat them or push them too far too soon. So yeah, if you have any questions, if anyone's ever gone through these, injuries, please let us know. We're always interested in hearing. If you are interested in working with us, again, reach out. Check out our website below for inquiries. Otherwise, again, we appreciate the subscription, and we will see you next time for part 4, where we will talk about the other 2 injuries previously in part 2. So until next time.